let me just first thank our two panelists, Lorna Thorpe and Stephen Berger, for our panel here on part of our NYC 2025 program, where we are discussing important topics in New York's recovery from the pandemic, but also the project was originally founded. I think Stephen was involved in it from fairly early on. We were interested in having smart policy proposals from people who had been thinking about important topics, given even in the absence of a pandemic. We were in the midst of at the time, a massive transition in city leadership between the mayor, the controller. I think it's about 2/3 of the city council, borough presidents, and then and now we have this year we have the governor's race and a bunch of legislative races as well. So the idea was that we were going to bring together leaders in specific areas and have good, thoughtful ideas and discussions around these ideas. So today we're going to focus on public health. We have two excellent panelists. It's nice to have a smaller panel to discuss this, because then it will give them adequate time to discuss their ideas. So we're going to actually first start with Lorna Thorpe, who is a professor and director of the Division of Epidemiology at the NYU Grossman School of Medicine in the Department of Population Health, where she also serves as vice chair for strategy and planning. Reflecting her career trajectory working in both public health practice and academic settings, Dr. Thorpe's research focuses on the intersection between epidemiology and policy, the impacts of policy and social conditions on health, and on improving population health surveillance. Dr. Thorpe currently leads several NIH and CDC funded research initiatives, including several on COVID responses, which will be, I'm sure, especially relevant today. And previously, Dr. Thorpe served as Deputy Commissioner of Epidemiology for the New York City Health Department. So Lorna is going to talk for somewhere around 10 minutes. If there are clarifying questions, attendees can certainly ask them using the Q&A function. Otherwise, we will then move to Stephen's presentation, and then we will have plenty of time for discussion afterwards. So Lorna, take it away.
Thank you. Thank you so much. And I just want to start by thanking you, Thad, and also Sherry Gleed and the NYU Wagner faculty who hosted this initiative and this event, as well as recognizing my collaborators on the paper that we wrote. I worked with Mark Arevich, Chow Trin Chevron, and Nadia Islam. We're all from NYU Grossman School of Medicine in the Department of Population Health. And these colleagues and several others here are really deeply involved in advancing the science and practice of community health worker-based initiatives. And that's what our paper was about, and I'm happy to present it. I do think it's important to set the context and take you back a little bit more than a year to late 2020. And we were still obviously under the prior administration. We had been through 2 waves of the pandemic, and we were beginning the upward trajectory of the 3rd wave. And at that time, the New York City Economic Development Corporation and Health Department jointly released a request for information to New York City public health experts and local leaders. And the RFI asked our views on strategies to build the city's public health infrastructure in ways that would promote health equity, that would build emergency preparedness, and would spark economic recovery. So very in line with what New York City 2025 is thinking about. And so we responded to the initial RFI, and we wrote about an idea that it turns out others were having too. And that was the idea of developing a robust community health core. And as we envisioned it at the time, it would be composed of a well-trained, always ready workforce of a smaller group of about 200 community health worker supervisors, and then a reserve of hundreds, we suggested 800 to 1,000 additional community health workers, not supervisors, but community health workers. And it would be modeled loosely on the idea of the National Guard, where during non-emergency times, those CHWs could be working in full-time roles in community serving organizations like schools, libraries, community-based organizations throughout the city and engaged in work reducing health disparities. And then during public health emergencies, some or all of that core could be rapidly deployed for tasks such as contact tracing, mental health, first aid, vaccination, education, etc. And a key feature of this idea was that the core would be highly diverse. Its members would be drawn from across the city in different neighborhoods and ethnic communities and hired from specific populations, NYCHA residents representing certain religions, specific languages, etc. And because of their shared life experiences, they would be trusted members of those communities. And that would be hugely important in the efforts to improve health equity. And it would be responsive to the community needs during both emergency and non-emergency times. And it turns out that right about that time, colleagues at the New York City Health Department were beginning to talk about a very similar idea. And just several months later, the city announced the creation of 2 public health core workforces composed of community health workers, many potentially hired from the Test and Trace program as it was beginning to downside. One of the arms would be coordinated by New York City Health and Hospitals Corporation. It's no longer a corporation, New York City Health and Hospitals, placing community health workers in primary care settings. And the other was a little bit more like what we were describing, and that was to be led by the health department, and that would place community health workers directly into community-based organizations, and it would be known as, it is known as the Neighborhood Health Corps. And the city announced that it would hire 500 community health workers to serve 20 high priority neighborhoods. So this was huge, and it was extremely large and ambitious program. It provides a large number of jobs to residents from lower income communities. It strategically links public health to economic recovery in population groups with the highest rates of unemployment and lower educational levels. And community health worker jobs are entry-level jobs. The challenge, the main challenge, is that long-term funding strategies for these cores remains unclear. And I believe still to this day, I know the city is working on it, but I believe they only have about 2 years of financial commitments, mostly from federal grants. And so what we submitted to New York City 2025 was a paper that focused on some of the challenges that this program is going to face. We first obviously took the opportunity to applaud the vision and the direction of the initiative, mainly because of the strong body of evidence that supports the impact of community health worker programs on improving health outcomes among vulnerable populations. And we definitely endorse the idea of placing community health workers in the local frontline community-based organizations, shoring up the very organizations that served heavily impacted communities most directly during the pandemic. But these programs only really work if they're run well. And so our paper focused on 4 elements that we felt were really important to rebuild trust and improve equity in access to health and social services, and to ultimately reduce health inequities. The 4 are clear health and social equity goals, sustained adequate resources, supportive supervision structures and opportunities to build capacity, and then improved communication between community sector and health sector. And I'm just going to briefly touch on each of those. In terms of clear health and social equity goals, we believe that the program really needs to work on 2 levels. Community health workers should be trained and resourced to identify not only the health needs, but the economic and social barriers that residents face, and to be able to provide referrals to meet those everyday needs. The residents need to see the system work for them, and community health workers need to know how to help residents build self-efficacy to address them over time. But at the program level, it's really important that these individual social and economic barriers be summarized, routinely analyzed, made public, to build awareness and foster interagency and cross-sector commitment to identify system-based solutions. And in doing so, it's really important that this core take an asset-based approach training community health workers on how to assist residents in identifying local assets and social supports within their community. The second was sustained and adequate resources, and this is the hardest one. The initial financial commitments are impressive, but in reality, these programs will take at least 3 to 5 years to develop strong infrastructures and to begin to demonstrate impact. So in our paper, we discussed 2 possible options for financing the programs, and I'm sure the city is deep in thinking about this. I haven't seen the latest or heard the latest on the direction the city is moving on this. The first would be working with the state to secure Medicaid reimbursement options. And the second would be going back to that reservist model that I described earlier. So currently, New York State does not have a consistent reimbursement or payment model for community health worker services. There are precedents around the country. In Minnesota, home-based services are provided by community health workers and they are reimbursed under Medicaid. And in some ACO or accountable care organizations around the country, those ACOs cover costs of home-based CHW services. Here in New York City, we have some health insurance payers and some hospital community benefit plans that support CHW reimbursement, but that really needs to be knit together. And so work at the city state level could identify long-term solutions, and that takes time. The second financing model would be more distributed. And this, as I said, is sort of the reservist model where community health workers within the core for the long term would be sustained by the CBOs and covered, the financing would be covered by the CBOs, but it would be subsidized by the municipal public sector as a sustained public health investment in reducing disparities. So you would need that full-time funding to cover the small backbone of CHW supervisors and then supporting a larger reserve. And the core members could undergo an initial in-depth training and then be called up for periodic training that could also include community service. The third was supervision and building capacity. And really CHW supervisors are the linchpin to a successful or a not successful program. And so we believe key elements of a strong supervision system include articulating clear hiring criteria for CHW supervisors, and that includes minimum prior experience working with patient navigators or CHW programs, and screening the supervisors to really make sure that they have empathy for and a clear understanding of the CHW role. The roles and reporting structures between CHWs and their supervisors and managers of the program need to be very clear and unambiguous. And I think this is particularly important when working across city agencies and community-based organizations. A system of training and peer support opportunities that provides supervisors with tools to manage CHW burnout and build effective communication between team members would be needed. And supervisors need access to transportation to visit CHWs, to really engage with what's happening in the field, to build strong relationships and improve performance. And finally, most importantly, to ensure retention, supervisors require adequate compensation and opportunities for growth. The fourth and final one was effective communication and referral processes between community organizations and the health sectors. And the vision for this program is really meant to be bidirectional for CHWs to refer residents to clinical services and for clinical teams to identify social needs of patients and make effective social service referrals and back and forth. And so the core really provides an opportunity to design and test innovative referral systems and bidirectional communication between social service community organizations and clinical settings. There are technology platforms that exist to make those connections, and that may indeed be part of the solution. But clearly the thinking and the organizational approaches are really important here. I'll end by just saying we do think that help from beyond government agencies will be important. There are clear opportunities to amplify the work of the public health core through strategic alignments with other community health worker programs across the city At my own institution, there are more than 60 community health workers employed, and we have a community health worker research and referral center that serves the city at Bronx Lebanon, here at NYU, and a number of other hospitals. Our community service plans support community health workers, and so finding ways to align programs on select goals can extend the impact of the city's core program. It's a bold initiative, and we think it really has the potential to make transformative and lasting effects on improving health equity. And I'm really happy to talk about it after perhaps Stephen goes next.
Thank you, Lorna. So our next speaker is Stephen Berger, who is going to he'll correct me when I say something incorrect, because we know each other well enough that he will do that, and that's his personality. Besides, he's going to talk about, whereas Lorna was focused on some of what the city was doing, Stephen is going to discuss what we need from the state to move forward. And there's really no one better to talk about what we need from that perspective than Stephen, who he is a member of the advisory board for NYC 2025. He was one of the original advisory board members. He is also he was the executive director of the Emergency Control Board for the City of New York during the fiscal crisis. He's the past chairman of the MTA, the executive director of the Port Authority. He's been involved in various important state public health efforts, such as the State Commission on Healthcare Facilities in the 21st Century, the Medicaid redesign team, et cetera. And perhaps most importantly, he has served in the past as an adjunct at the Wagner School. And maybe we'll get him back eventually as well. But Stephen is going to walk us through, again, what we need from New York State in terms of public health delivery services, et cetera.
Thank you, Thad. It's clear when you list that I can't hold a job. What I'd like to do is I'd like to start with the state, because the structure of the state from a regulatory and a financing point of view is central if we want to really fundamentally change how we deliver healthcare in the city. And I start by saying the state structure is in its best moments. It's dysfunctional. There are 5 state agencies, who have health in their name: Department of Health, Mental Hygiene, Substance and Abuse. And there's a 6th, which is absolutely crucial, which is the Department of Financial Services, which controls and funds the health, the health insurance industry. Now, not only is that wasteful and in terms of the state level, and costs hundreds of millions of wasted dollars, what you have is a bureaucratic infrastructure which is committed to protecting itself. What's much worse is that we're a state supervised and locally administered system. So those silos come plunging down into the heart of the healthcare system in every county and in the city of New York. And it's a piece of why we cannot and have not created an integrated healthcare delivery system. The fact that we can't put the behavioral and the physical health together is partly because they live with different regulators, different funding sources, and it creates the lack of cohesiveness you need to have an integrated healthcare system. That's one issue. The second issue is, without getting lost in the funding, we have created in the United States a funding system coming out of World War II, which came out because the hospital system in the United States was totally inadequate after World War II. The Fed started putting money in, and money creates what comes afterwards. And so what we did was we created a historic sick care system built around the hospital system, and that was not a preventive care system. And if you look at that, there's an embedded infrastructure that resists. And we're going to come to talk about what Lorna suggested. There's an embedded infrastructure. It's not evil. It's an embedded infrastructure of buildings, of unions, of professional structures, just inside the physical side, which give you, and with all due respect, even to NYU, which is one of the better run hospital systems, a siloed delivery system across the institutions. And by the way, just parenthetically, we didn't learn anything about from COVID. We knew that we had poor healthcare in a lot of communities, and not just the minority communities, by the way. Upstate and in the rural communities also have some of the same problems. The other thing we did was we created in the minds of people, our consumers, the notion that healthcare and hospitals are synonymous. Hospitals do not equal healthcare, they equal sick care. And we haven't dealt with preventive care. The third piece in some of my experience, and by the way, I screwed up on this. I was state social services commissioner. I headed the commission on healthcare, and I really walked away from everything except fixing the sick care institutional system, because it was much too complicated, as Lorna and her colleagues are finding out as we're doing it. We spent $8 billion under DSRIP. DSRIP was the Delivery System Reform Incentive Payment Program, came from the federal government, and it was meant to really reach out into communities and help with the access issues and with reducing racial inequalities. And despite what all my bureaucratic friends and all the state government friends and the federal government friends say, we did a piss poor job. Okay, and we did a piss poor job because it was being done through the white coat system, through the hospitals. They can't integrate themselves, let alone reaching out to integrate into the communities. And the second part of it I'll come to in a moment is that the people that we're trying to reach out to did not have infrastructure so they could integrate even if they wanted to. So if we're going to attack this, we have to attack it in some different way at the core. And I have the paper I wrote goes back to, it starts with something I suggested to Governor Hugh Carey 40 years ago, and he bought, and of course the city fiscal crisis came and A-Beam disappeared and we couldn't do it. My first proposal was to create a true integration between the city and the state on delivery systems, and to do that by having the governor appoint a deputy state health commissioner and the city to appoint a deputy health commissioner, both of whom had the full support of the mayor, and parenthetically, the full support of both budget divisions at the state and the city, since we know the budget divisions run the state and the city. We should have no illusions about that. And they would work to create the network for integrating. And it's SUNY and the Health and Hospital Corporation. It's integrating the delivery cores, and they would have and this would be a multi-year process to begin to break down the regulatory barriers that exist between the agencies and between the state and the city. Unfortunately, it did not take place. The second issue that I think we have to deal with is that we fund sick care and we fund institutions and we don't fund preventive care. And what do we put 5% of these billions of dollars into primary and preventive care? You know, with all due respect, it's a joke, but you go and try to take $1 away from anybody in the core infrastructure. You know, everybody believes the dollar they have, they've got to have the most important, they're the most important healthcare element. And not only that, it should really be $1.10. So, you know, to start to take it away is very hard. Rhode Island, among the states, has done a very interesting job. They picked out all the core codes that are preventive primary care codes. And doesn't matter who's delivering it. They passed a regulation years ago which said every year you have to increase your primary and preventive care by 1%. By the way, if you go from 5% to 10% over 5 years, you will change the shape of healthcare delivery. So that's one of the things that we have to do. Another thing we have to do, by the way, the problem in the minority and rural communities is not just dollars, it's access. Access is a much more complicated notion. And now what we did learn through the COVID experience was that you could have access, you have technology, which now helps. By the way, getting the technology through the five regulatory state agency is a royal pain in the ass, okay? But you have technology which can be used to help reach out into different communities. And the other thing, the state has got is powerful regulatory powers. And so they can use those powers, like the certificate of need approval and the funds flow, dealing with even the great powerful white coat institutions, to begin a process of both the funding and to create a distributed system of healthcare access and delivery. By the way, a lot of the hospitals, people say we need more hospital beds. We don't need more hospital beds. In fact, a lot of those community hospitals, people really don't want them touched for two reasons. They provide real employment into the communities, but more than that, they want the downstairs. The downstairs is where the doctor's offices are, where the emergency rooms are, because they call their own doctor and they say, I'll see you in 2 weeks. But they're not crazy about upstairs. They're smart enough to know they'd rather be at NYU upstairs than at the call it hospital, which I'm not going to mention because they all hate me anyway. So I think that what I'm suggesting is that we've got to move the dollars into the primary care. Secondly, we have to force the integration of behavioral and physical. And that's got to be the governor going through those agencies and saying, cut the crap, we're going to have a single regulatory process. The third thing we have to do, and now I'm getting to Lorna's piece, we have to attack how we fund those services that are really public services, but have been offloaded outside the government structure, the not-for-profit organizations. We underfund them. We don't fund them for development. We don't fund them for IT and infrastructure training. And then we say, gee whiz, we try to work with those people. They can't, well, of course they can't work with you. They don't have the infrastructure, they don't have the training, they don't have the financial support that's necessary. So what we have to do is begin through the healthcare financing system. And that includes Medicare and Medicaid and the health insurers. We have to begin to fund and train. This is, by the way, this ain't making instant coffee, guys. We're not going to pour water in and have undrinkable Nescafe. This is going to take years of commitment and training, and it's going to take a combination of the city and state bringing the political forces together to take on the entrenched dollar holders of our system. And by the way, that's not easy. That's not just the governor and mayor. That's the state legislature. It's the city council. People have to understand that we're not going to create the access and availability and the integrated system unless we fundamentally change. And so the core of really what I'm saying is, this is not just a structural debate. This is a core political debate about how we're going to take care of people. And unless that debate is joined at that level, we're going to continue to have piecemeal pieces of hard work, as Lorna has described, and as other people have described. We will not have a distributed system of access to healthcare for the bulk of the population. So my paper was really aimed at the political leadership, which has avoided any of this because it brings them into conflict with powerful forces, labor and management, and the institutional healthcare network. Other than that, Mrs. Lincoln, how did you enjoy the theater last night?
Thank you, Stephen. Do we have any, we have time for conversation. Does anyone have questions? Otherwise, I'll I'll try to kick it off, but I did want to, have anyone who might have questions. If either of you have questions for each other, you're certainly welcome to ask them as well. Otherwise, I would start with, so Stephen, you had mentioned that this is going to require sustained change, that it's not something that's going to happen within one period of time. So what is it? I mean, do you have a sense, is this something that's actually possible? I mean, we had a long-serving governor who did not have the wherewithal and you made it very clear that this is not just a governor responsibility, although a governor would obviously be necessary, but not necessarily sufficient to accomplish what you were talking about. Do we have the political wherewithal to get this done in the current structure of New York State, or do we need to think about something like, I hate, you're going to hate when I say this, Stephen, I apologize, but do we need a commission? Do we need to move it out of the political process and into something that we just say, here is your task to make it work, and go make it work?
No, I've been through that one.
Yeah, I know you have. That's why.
When we got done with what they called the Berger Commission, the governor said to his office, we may have another one of these, but we'll never have one with a guy like Berger running it. I think what you have to do is you have to sneak up on it. You have to do two things. You have to sneak up on it, and you have to lay the first steps very carefully so you don't frighten people. And what I would suggest, and there's a bill in the state legislature, and it may have been passed, I don't know, which basically sets up a starting commission that does what Rhode Island did. And that is to set up the codes, which are preventive and primary care codes, and pass regulations. So the hospitals can't claim it's against them, the doctor's offices can't complain, and requires a 1% a year increase in preventive care. Now, even Greater New York Hospital Association, my friends over there, can't argue with that, but that's the beginning. And so that's sort of a sneak approach. The second thing that the state can do is talk to its regulatory bodies and say, and we saw this during district, stop this nonsense about different regulations for behavioral. And by the way, the mind and the brain happens to be part of the body. I know that the healthcare industry hasn't necessarily noticed that, but the fact of the matter is that we've got to have a single regulatory support, and that could be done inside the bureaucracy. And the third thing is when some of the great institutions, like one of the ones that Lorna works for, and there are, depending upon how you want to count them and what their balance sheets are, 3 or 5, and there are a couple upstate, when they come in for certificate of need improvements on building another building, right, which has maid service and the cuisine is high French level for the people. When they come in with the desire to build more institutions, the answer is you cannot do that. If you want approval, we want to see how many outpatient distributed care facilities you're going to put together. And that's not just building, that's staffing and improvement. And the fourth thing that the state could do, which would make the governor and the legislature and the mayor all look like wonderful, wonderful, competent people, is they got to really fund a new level of medical personnel for the state of New York. It's a national problem. I mean, you got 45 and 48-year-old doctors retiring because they're burnt out. Okay, we have got to fund, and the funding program, there's a little one now, that'd be big one, which says, if you are willing to commit to work for 5 or 6, I said 6 years and they cut it back to 5 years in an impacted community, a community which is underserved, whether it's in Brooklyn or the Bronx or in Dutchess County. If you are willing to commit for 5 years, not go on to become a dermatologist so you can get paid for Botox, but if you are willing to commit 5 years to work in these communities, we will pay your medical school. We will wipe out your medical school bills and pay for them. And this should be for docs, for PAs, PAs, for nurses, for NPAs, and it should also be the beginning of a program. The unions will like this one, a beginning of a program to train and upgrade home health care aides, and to give them a career, a wage that's supportable, and a career path for those who want them, who will be case managers in our new distributed system and who will work with the population, and to fund the kinds of programs that Lorna is talking about with training and practice and all the rest. Other than that, I'm on the second act of the theater. So Mrs. Lincoln is now worried.
Can I ask a question?
Of course.
I'm really interested in how long Rhode Island has been working at this, and what do you know about early impacts?
I can tell you this has been going on now, I think 4 or 5 years in Rhode Island. And by the way, if we really want to understand the impacts, we have a source in this state, the New York State Health Foundation, David Sandman is running it, has been studying the different programs in different states. Many of them are really in infancy. And they've done some work on trying to track how some of this is going. And I think that's a place for us to look, to study what's happening.
It's interesting that you noted that there's a sort of a cleavage between, mental health and other services. And it's not just New York State that has that issue. It's a national issue. The other one that always surprises me that it continues is how dental is considered separate from general health care, given the impact that dental hygiene and health can have on someone's physical health and well-being. There are several of these that are what's the right way to put it? Quirks of history that we have never dealt with, not just in New York State, but nationally as well. It is an absolute path dependency mistake of history that health insurance doesn't cover. For example, routine, as you were saying, preventative dental care, which is relatively inexpensive compared to, say, a root canal. So it's quite a path dependency we have in healthcare. So thank you. Sort of along that same, let me ask Lorna a question. And again, if other people have questions, you should feel free to jump in. You also point out that one of the issues in the delivery of services in communities is coordination between city agencies. You talk about the Department of Health and health and hospitals. Is there a way? How do we keep ending up with all of these public agencies involved in health? So we've got all these agencies involved, and yet no one seems to be in charge. So what are the coordination problems that you saw when you were at the Department of Health, Lorna, that you, and I know this is a huge question, but are there, Stephen talked about how there might be ways of having changing codes or having preventative care increase over time. What are some of the issues you saw that are, because what I'm trying to get at, the theme I keep hearing when I talk about public health or health in general is that we've got lots of elected officials who have ideas for new programs. But a big chunk of the issue we have is a governance and management problem. We spend a lot of money on this, but we don't spend it wisely. We spend it across agencies who everyone is in charge, so no one is in charge. And we see it at the state level, we see it at the city level. So maybe Lorna, you can speak to some of you can tell me I'm wrong. You can tell me, what did you see while you were working at the Department of Health?
Yeah. Well, first of all, let me put it in context. I was at the health department under Bloomberg and Tom Frieden, and that was a very different administration than today. I will also say that during the pandemic, there was sort of unprecedented need for city agencies to work together, and a lot of learning happened there, and there were a lot of pain points. I can't speak with sort of the knowledge of that experience. So I just want to sort of put that out there. But I do think when I was there, part of what I saw as the sort of a best practice, which we didn't do enough of, was to work together from the outset on initiatives where we're at the table and we're really finding win-wins for multiple city agencies. And we're saying, let's look at the data. We'll lead the data analysis. You help us lead the solutioning. Let's think about a 6 months, 2 year, but if high level involvement, sort of, what I call policymaker based participatory research is happening, then they're invested in the problems that are being identified. But if if one city agency is identifying a problem that involves another city agency, and that other city agency hasn't been involved from the get-go, they don't move on it. They react defensively, and you have your usual challenges. So if you have an effective, this sounds, perhaps Stephen, I think, could probably answer this maybe even more knowledgeably than I can, but if you have an effective leadership with targeted goals, and around those goals you have sort of problem solving with the right level of leadership, then you can begin to work together to identify proactive solutions that are, basically grounded in reality. I saw that happen around issues around dealing with the health of homeless individuals, which spanned multiple institutions. I saw that happen around bicycle fatalities and car crashes, which involved the police, transportation, health department. I think in an emergency, things really shift radically, and so having sort of clear plans for what to do in an emergency is a good idea, and often does get thrown out the window at the time, when things really hit the fan. Stephen, what are your thoughts?
Part of the problem we face is that for senior public governors and mayors and all the rest, healthcare is not the place you want to land. I mean, you don't want to be in you don't want to be in the middle of education. You don't want to be in the middle of healthcare, because it goes into communities and you've got lots of embedded resistance. And without that, I'll give you an example during what happened in COVID. During COVID, people weren't going to the doctor's offices, and the mental health side, people weren't visiting their psychiatrists. The commissioner of the Department of Mental Hygiene, and so she just told everybody, talk to them on the phone and we'll pay you as if it's an office visit. The Department of Health came to that position about 2 months later. I mean, and it's not just getting the top people sitting around a table. They have to change the way the bureaucracy works in all of those agencies. And the key to some of it is that you can't integrate everything right away. It's just not possible. You have to pick a couple of pain points. All right. And that's why I focused on behavioral and mental. And the state has to pick, and they can do that through regulation. They pick a couple of pain points, put them together and fund. And you know what will happen? If it works, then they can they get the legislatures involved and they get other people, but you work it step by step. But you have to have a long-term commitment. Infrastructure, we know what infrastructure, we talk about what Con Ed's digging in the city, that's infrastructure, right? But the human infrastructure is just as deep and just as complex and requires as much time to change. That requires of the political system, which we don't really do a good job of, to really think through a multi-year and commit to a multi-year set of changes. I think Bloomberg did a better job of that than a lot of people. Hugh Carey, actually Nelson Rockefeller and Hugh Carey in different areas did a lot of that. But to get them to focus on healthcare means they're taking on different units. I mean, by the way, guys, just for fun, you have Downstate Hospital, and across the street, you have Kings County Hospital. They're two separate hospitals in the state. One is a state, one is a city hospital. And the fact of the matter is they ought to be a single integrated delivery system, and they're not, because the politics and the history, that is totally absurd. And so how you get around the absurdness, Lorna, I don't know. I'm waiting for a healthcare leader, the way we've got leaders who invest in infrastructure and invest in, in all kinds of other things. And I'm waiting for somebody, and hopefully the present governor may be that person, who is willing to commit her resources to making change.
Yeah, it's interesting because I've heard you, obviously we've talked in the past about other issues, but the idea that you can really only pick, 1, 2, 3 main issues and deal with is really a significant notion that sometimes get lost in this. It's when you and Lorna go through the problems or the constraints of the current system, it seems that this would take a lifetime, and maybe it would take a lifetime to fix all of this. But like you said, if you pick 1 or 2 things and just chip away at that over a few years, you can actually make incremental change that is in itself meaningful, but then leads to further change. The Rhode Island example for that you brought up is a great example. And so I think sometimes that gets lost in reform efforts, that there has to be this pull it all out at the roots all at once, and that's never successful, or it's rare. I should say it's rarely successful. And when you have so many entrenched interests, you're never going to politically get that done, especially in a place like New York. So I think that's a good takeaway from both of your discussions today.
There's a part of that you got to add, and I think of the people who did it better than other people. And I said Nelson Rockefeller, Hugh Carey, Mike Bloomberg did it. You pick 2 or 3 issues. Smoking. Okay. You pick 2 or 3 issues, but in order to make the system run, you got to pick really good people that you trust and back to deal with the other issues, which are serious issues. And the 3 guys I named, if you look at the people they hired and gave commissioner jobs to, they were really good folks, talented people, and they were backed and supported by the political system, but that left the key leaders to focus on the things they chose to focus on.
I think you just said a critical difference between the leadership under the one I experienced and what happened during the pandemic. I think a lot of what the challenges that the city agencies faced was that there was not that right. support, nor did we have exactly the right leadership right. in place to really carry us through that time.
Bozo didn't work very well.
I think that's actually that is an excellent point. It speaks to the importance of competent and good management, even if it's not in an area of high priority, even in areas where it's not popular and sexy, whether it's something like a general services administration or, the Department of Finance. These are important agencies which require competent leadership so that other leaders can be focused on those key 2 or 3 tasks like you were talking about. So we are almost out of time, and in the interest of keeping to schedule, I'll throw out, if there are any last second questions, but otherwise, I did want to thank both of you, Lorna and Stephen, for taking some time to chat with us this morning about your papers. As always, I learn more from talking than just reading, so I appreciate this, and I hope the attendees also did. And we will be having more of these conversations. We have one at 10 o'clock. We have some on Friday this week. And then the week after next, we have some other panels for NYC 2025. So I hope to see other people and other speakers and other attendees at those as well. So thank you all very much. Appreciate it.
Thank you for hosting us.
Thank you.
Take care.